I don't know what happened. But I hope you've done your dry run and you're ready to go.
Yes. So
Oh,
am I now visible?
fantastic. Let
Can
me
you see me now?
not quite view.
See what's going on. Okay. I can see you.
Okay.
Yes, we can see you now. Yeah.
Yeah, yeah.
All right. Fantastic. All right. All the best. You'll do well.
Thank you. Good evening, Dr. Eskinder. I have been
Good evening.
practicing this, how to pronounce your name.
Yeah, you're right. You pronounced it right.
Okay. The other one, let me see. Other one, I think I'll get it right as well. Girmachew. Hailegiorgis.
You can only say Eskinder.
Okay. I think the Eskinder is better.
Yeah, yeah.
Okay. African names are African names are
Yours is also
peculiar.
difficult for me, yeah.
My own name is also sometimes difficult to pronounce.
Yeah. አዋዬ ደሜ አለው ደህና ነኝ። እኔ ስኩል ነኝ፣ ስኩል ኦፍ ሜዲሲን። አዎ ጠፍቶ መጣሁ። ስቲል ጄኔሬተር ባካፕም ነበር እና ስኩልና ምን ችግር አለ? ስኩል ይመቻል? ሩቅ ነው? አይ ኢንትሮዳክሽኑ ላይ ትኖርና በኋላ ጥያቄና መልሱ ላይ ነው የምትኖረው። ማለት ኢንትሮዲውስ ሲያደርጉ አማ አለው ለማለት ነው ማለት ነው። ከዛ መጨረሻ ላይ በኦዲዮም ትችላለህ፣ በኦዲዮም ትችላለህ። አዎ በቃ እሺ፣ ችግር የለም። እሺ እሺ እሺ። I was talking with our expert, and
Okay.
he's having some connection issues, and he's sorting that.
Okay. All right.
Maybe do you need the slides? Shall I share you?
Yes, please. Yes. So that I will be familiar with it.
I've sent.
Okay, let me check. As we are closing in to time, I think there are a few colleagues already in. Good evening from Sierra Leone. We still have 2 minutes to go before we formally start the webinar. Well, I'm seeing Dr. Chik Kasa. Good evening. How are you? And I'm seeing also Dr.
Good evening.
Chama.
Thank you.
Right. And I'm seeing who else? Dr. Afran, Dr. Charles Oku, Dr. Collins, Dr. David Jalo, Dr. Bruno, Dr. Muntata. Good evening to you all. I think I'm seeing Rome and Yabi Solo. Good evening to you all. From my end, the time is 17 hours GMT. Good evening again from Sierra Leone. I am Dr. Rosalie Tajay Datubabu, and I will be moderating this session. And I am the Watog representative for Sierra Leone in Freetown. Welcome to the World Association of Trainees in Obstetrics and Gynaecology, Africa, Bimonthly clinical case series. Today we are spotlighting Ethiopia in what we promise to be another rich and insightful session. This session will have the following. We'll introduce the panelists. We'll have case presentation by Dr. Eskinder, and then we'll have expert opinion by Dr. Demsash Aliu, and we'll have the Q&A session and then conclusion. The topic of discussion is management of abortion in individuals with bleeding and thrombotic disorders. Let me start first by introducing my panelists. The first speaker will be Dr. Eskinder Girmachew Hailegiorgis. He's an obstetrician gynecologist. He completed undergraduate degree of Doctor in Medicine in 2018 from the University of Gondar. He served as lecturer of obstetrics and gynecology from October 2018 to February 2021 at the University of Gondar. He also completed his residency in obstetrics and gynecology at Yekatit 12 Hospital Medical College, Addis Ababa, in March 2025. Currently, he's working as an assistant professor of obstetrics and gynecology at the University of Gondar, Comprehensive Specialized Hospital, Gondar in Ethiopia. He is the current Watog representative of Ethiopia. The second speaker will be Dr. Demsash Aliu. He is also an associate professor of obstetrics and gynecology at the University of Gondar, Comprehensive Specialized Hospital. He has a subspecialty in family planning and reproductive health. I will further introduce him when he's about to start his presentation. Without more ado, I will now give the floor to Dr. Eskinder to start his presentation. Thank you.
Okay. Thank you very much. Is the slides visible?
Yes, please.
Okay, thank you. Thank you all for attending our session. And our today's case presentation will be on the management of abortion in individuals with bleeding or thrombotic disorders. And as the moderator described, the expert will be Dr. Demsash, and our moderator is Dr. Rosalita. And this is the bio of me, as well as the expert, as well as the moderator. And the outline of my presentation will be on patient's profile. We will discuss about the case, and then we will discuss about the management of abortion in individuals with bleeding disorders or on anticoagulation. Then we will discuss about the management of abortion in individuals with thrombotic disorder. Then we will summarize. And when we look at the patient profile, this is a 40-year-old premi-gravid Ethiopian woman. Her gestational from Addis Ababa. Her gestational age at presentation was 8 weeks, and she's a non-cardiac patient with a mechanical valve for severe mitral regurgitation, and she's on warfarin. Since the surgery, since the repair, and after the pregnancy was diagnosed. Warfarin is changed to enoxaparin, and she was also on bisoprolol after the surgery and discontinued prior to the pregnancy. She presented.
And this will check Google Classroom for your maths work.
Sorry. Okay. She presented to our hospital for termination of pregnancy, and she has no symptom of cardiac failure, bleeding tendency, from any sites. On physical exam, she is well looking. Her blood pressure was 120 by 70 millimeter of mercury, and her pulse was 88 beats per minute, and it was regular. And her respiratory rate was 18 breaths per minute, and temperature at 6.5 degrees Celsius. She has pink conjunctiva and non-extravascular sclera. Chest was clear, and JVP was flat, and no murmur or gallop, and no peripheral edema, and no sign of cardiac failure. On investigation on lab workup, complete blood count, hemoglobin was 12.4, and platelet was 180,000, and her blood group was O positive. And on coagulation profile, both PT and PTT were in the normal range, and INR was 1.4, and transesophageal echo was done. It was normal, and on pelvic scan, there was a singleton gestation. Fetal heartbeat was positive, and gestational age from the crown ramp length was 8 weeks. For this, the cardiology team was involved, and they were consulted. And the plan there was to change enoxaparin into unfractionated heparin 72 hours prior to the procedure. And for that, it was changed into unfractionated heparin. And on the third day on unfractionated heparin, in the morning dose of unfractionated heparin was held, and MV was done with paracervical block. And the procedure was smooth, no complication, and the woman was counseled on the mode of contraception, and she chose natural methods. I will proceed with the discussion. As an introduction, normal pregnancy is accompanied by a change in hemostasis, especially leads to hypercoagulable state. And compared to non-pregnant, pregnancy places women around 5 to 7-fold increased risk of thromboembolic disorders. So the causes for this pregnancy-induced hypercoagulability could be: one is increased venous stasis, especially due to compression of inferior vena cava and pelvic veins by the enlarging uterus. which is less common in the first trimester. And the other is changes in the coagulation cascade. This means increment in several procoagulant factors and decrease in natural inhibitor of coagulation and reduction in fibrinolytic activities. So these cascade changes also increase the risk of hypercoagulability. The other is might be basal injury. These are the risk for coagulation, hypercoagulopathy in pregnancy. So when you look into tests of coagulation during pregnancy, most are unaffected. Most tests are unaffected, and the prothrombin time, the activated partial thromboplastin time, thrombin time, all for slightly, but within the normal limits. So the bleeding time is also unchanged. Then the testing for von Willebrand disease are affected, especially for this disease are affected because the levels of factor 8, von Willebrand factor, activity, antigen, as well as reticular factor all increase. Because of this, the testing for von Willebrand disease are affected. Then I will proceed with the management of abortion in individuals with bleeding disorders and on anticoagulation. There is a little known about how common we encounter individuals who need abortion, especially for bleeding disorder, thrombotic disorder, or patients on anticoagulant. There is little known or there is little data about this condition. And individuals with bleeding disorder are at a greater risk for increased blood loss and hemorrhage. So when should we suspect bleeding, especially in these individuals? When do we suspect or for whom we should suspect bleeding disorder? So bleeding disorder should be suspected in individuals who have heavy or prolonged menstrual bleedings, easy bruising, epistaxis, excessive bleeding after medical or dental procedure, and family history of bleeding disorder. So these things might give us a clue whether there is a bleeding disorder or not. So the common bleeding disorder usually encountered are one is von Willebrand disease, the other is thrombocytopenia and coagulation factor deficiencies. Especially von Willebrand disease is the commonest of all bleeding disorders, especially the most common inherited bleeding disorder. Its prevalence is around 1%, and the symptomatic von Willebrand disease is estimated to be around 0.01% prevalent. So the increased levels during pregnancy leads to progressively higher levels of von Willebrand factor over the course, especially second and third trimester pregnancies, which mitigates extent of bleeding, especially in women with symptomatic von Willebrand disease. Especially in the type 1 and type 2 von Willebrand disease, this physiologic check might help to mitigate bleeding. But in type 3, there is an absolute deficiency, so that can't help. That physiologic change can't help the bleeding in hemostasis. And the other is thrombocytopenia. Thrombocytopenia is a moderate moderate decrease in platelet counts are commonly seen, especially in later stage of uncomplicated pregnancies. And platelet less than 60,000 were seen in around 1.25 per 1,000 pregnant women in the first trimester, and in 1.75 per 1,000 women in the second trimester. So the risk of bleeding in thrombocytopenia increases, especially if the platelet count is below 50,000. So below 50,000 is also another risk factor for bleeding. The other is coagulation factor deficiencies. Although it's less common, it's also an important cause of bleeding. One is factor 5 deficiency, which is 1 in 500,000, and factor 13 deficiency, which is 1 in 2 to 3 million thousand. These factors are also, the deficiency of these factors is also cause of bleeding. The other group who is at risk of bleeding is anticoagulated individuals, like our case. So it's not uncommon to encounter such individuals requesting abortion. So the number of women, especially individuals taking anticoagulants and antiplatelets, is increasing recently, especially due to multiple factors. One is due to increased cardiovascular and peripheral vascular diseases. The other is prolonged survival after surgery, especially for congenital and acquired heart diseases. The other is increased prevalence of diabetes and hypertension, which leading to strokes. So due to this condition, patients with oral anticoagulants are increasing, and it's expected to increase even in the future. So this is important topic to discuss. And pregnancy, mechanical heart valves, and therapeutic anticoagulation. So our mother has these all three conditions. So pregnancy presents a unique set of problems in such women with prosthetic valves, especially mechanical valves needs a long-term therapeutic anticoagulation. There is no there is absence of relevant randomized trial to make it difficult to offer definitive recommendation or anti-thrombotic regimens for prosthetic valve during pregnancy. So there is absence of or there is lack of evidence regarding this condition. So a woman with a mechanical prosthetic heart valve should be counseled strongly that pregnancy is risky, and because of the risk of embolic phenomena. So counseling this woman on family planning or on contraception is a must. So in women with mechanical valve, pregnancy in women with mechanical valve is associated with very high risk of complication, and it's classified into modified WHO risk classification 3. So it's associated with high risk of complications. And when we see the maternal mortality, it's around 1.5% compared to 0.2% in women without these prosthetic valves. And bleeding complication occur around 20% of women with mechanical valves, and valve thrombosis occurred around 5% of the population, the same population. So still the condition is highly morbid. So patients who are pregnant and who want to have abortion, then what is the ideal setting to manage such patients? So the ideal setting, it's expected that any abortion in such patients has increased risk of excessive bleeding. But first trimester abortion usually is associated with less bleeding, especially less than 100 ml. So it can be done in other setups, but it's recommended to refer patients into a hospital-based provider when they are first trimester and they have associated risk factors of bleeding, like our patient, or second trimester abortions, because they both have risk of complications. So they should be managed in a place where there is backup blood, where there are professionals, MDT is present. So there should be a strong backup so as to manage such complications. So the first, so managing abortion in resource-limited challenges, such case specialists challenging. So if they are first trimester, for patients who came for first trimester abortions, there is no published data to choose between medical or procedural abortion. There is no published data, but procedural abortion usually likely not result blood loss more than 100 ml, but data overall safety is still lacking. It still is lacking. But when you go to medication abortion, it's not recommended, given that it's unpredictable and heavier nature of the bleeding following this medical abortion. So generally, procedural abortion is preferred in the first trimester. For the second trimester abortion, surgical management may be recommended to limit bleeding, though it has not been fully studied in this population. But surgical management is recommended to limit the bleeding. So individuals suspected to have second trimester procedural, individual presents for second trimester procedural abortion with bleeding disorder, prompt referral to haematologists should be initiated. It's grade 1C recommendation by Society of Family Planning. And procedural abortion, when you look into the procedure, we have said it's preferred over the medication abortion and procedural abortion. So uterine aspiration is the commonest procedure in the first trimester pregnancy, either manual or electrical vacuum aspiration. And dilatation and curettage is still being performed in the first trimester, although using sharp curettage is discouraged. So dilatation and evacuation is a procedure used significantly to manage second trimester pregnancy termination. So while performing or before we are doing performing, there are risk factors which will increase bleeding. So there are potential factors which might increase bleeding during procedural abortions. One is higher gestational age, especially second trimester has high risk of bleeding than the first. Multifetal pregnancy, prior cesarean section, or any major uterine surgery, abnormal placentation. The other is baseline anemia, or whether there is anticoagulation dosing, whether it's therapeutic or prophylactic. That also matters. So the therapeutic one increases the risk of bleeding. So the other preparation that we should make is preoperative hemoglobin. So the hemoglobin thresholds for procedural abortion, especially in outpatient settings, hemoglobin should at least be 8 grams per deciliter. So unless the hemoglobin is greater than 8 grams per deciliter, it's not recommended to provide outpatient abortion in an outpatient setting. So in a hospital-based setting, hemoglobin less than 7 grams per deciliter, procedure should not be performed unless otherwise there is available intraoperative or pre-operative transfusion. So we need to have a backup as well. We need to have pre-procedure transfusion, or we need to have a backup, blood backup, so as to perform this procedure. Then during the process of the procedure, we might implement some techniques to help reduce blood loss, especially desmopressin is one of them. It is important, especially in those who have bone growth factor deficiency. And in such cases, it stimulates bone growth factor from the endothelial cells, and so it will help especially in the type 1 volume blood disease and mild hemophilia and some platelet function disorders. So this can sometimes be given. The other way of decreasing is paracervical injection of vasopressin. We can give this with paracervical analgesia too. So it will decrease the risk of bleeding too. The other is prophylactic oxytocin, especially in the late second trimester terminations. We can also provide prophylactic oxytocin so as to prevent or to lessen the blood loss. The other thing is about analgesia, especially if we need neuralgical block, especially in this group of patients, we should change, as we have discussed, we should change warfarin to either low molecular weight heparin or unfractionated heparin. And for those receiving unfractionated heparin, minimum 4 hours before the procedure, or for those who are taking low molecular weight heparin, 24-hour interval should be there between the anesthesia and the procedure, the medication, the last dose of medication, and the anesthesia. The other thing is perioperative management of anticoagulation. Whether to continue, interrupt, or discontinue, the medication should be individualized. It should be a case-by-case level decision, as well. It should be a multidisciplinary team decision. We should involve haematologists as much as possible so as to decide whether to continue, interrupt, or discontinue this medication. Usually, we can follow similar guidelines. In the perioperative period, we can implement same guidelines as of non-pregnant individual who undergo general gynecologic surgery. So evidence-based scoring like Caprini score might help to provide further stratified patients with venous thromboembolism risks and subsequent anticoagulation management in certain patients. So this score can also be used to provide. Then the most important thing is consultation with hematology should be considered, especially individuals with high risk of thrombophilia, individuals who are already on anticoagulation, especially therapeutic, and individuals who have a coagulopathy and or are anticoagulation who are undergoing more complex procedural abortion. So individuals who may have coagulopathy or on anticoagulation who are undergoing more complex procedural abortion, for those individuals, it's better to consult hematologist. So when we look into first trimester procedural abortion on anticoagulation, there is no additional risk factors of bleeding to undergo procedural abortion that's anticipated to be uncomplicated. So anticoagulation can generally continue uninterrupted. It's great to see recommendation, and anticoagulation can go uninterrupted, especially in the first trimester procedural abortion. In the second trimester procedures, these are associated with greater blood loss as bleeding, especially excess of 500 ml, requiring intervention should be defined as post-abortal hemorrhage. So, especially for the second trimester abortions, there might be anticoagulation interruption and reinitiation. So, temporary interruption of anticoagulation should be considered in the first as well in the second or in the second trimester abortion, especially for those who have significant risk factors for bleeding. So the decision to interrupt should be individualized, must be individualized, especially those with absolute risk factor for VTA, VTE, or venous thromboembolism. Anticoagulation is to be interrupted and bleeding risk with anticoagulation if it continued. So we should balance between bleeding and thrombosis. So while we need to interrupt, or the timing between hours before the procedure and hours after the procedure for whom to initiate is listed. These are the anticoagulant medications. First, we see unfractionated heparin. So unfractionated heparin should be given 6 hours before the procedure. It shouldn't be given earlier than 6 hours, and it can be restarted after 6 hours of the procedure. It shouldn't be started earlier. The other is low molecular weight heparin like enoxaparin. For this, especially for prophylactic dose, it should be given 12 hours prior to the procedure and 6 hours post procedure. The other is warfarin. For therapeutic dose of low molecular weight heparin, it should not be given earlier than 24 hours, and for the therapeutic dosing, it should be started 12 hour. It should be started 12 hour post procedure. For warfarin, before the procedure, it should be at least for 5 days. Warfarin should be stopped at least for 5 days before the procedure, and it shouldn't be reinitiated after around 12 to 24 hour post procedure, because the half-life of the effect of warfarin lasts around 5 to 7 days. We should be cautious when giving warfarin. The other drugs are direct oral anticoagulant like rivaroxaban. They should not be given before 48 hours of the procedure and within 24 hours of the procedure. So this table overall summarizes when to give these anticoagulants before and after the procedure. The other concept is anticoagulation bridging, shifting from one anticoagulant into another coagulant. So when you say bridging in an individual, especially particularly at high risk for thrombotic events, for example, in individual with pulmonary embolus in the last 3 months, severe thrombophilia, or individuals with artificial valves, bridging anticoagulation can be employed, but only multidisciplinary team management discussion. But after only multidisciplinary management team discussion. So in anticoagulation bridging, we will initiate intravenous or low molecular weight heparin with discontinuing warfarin to maintain full anticoagulation effects while the warfarin resists. So it's bridging from warfarin to heparin. So Society of Family Planning advises to start bridging therapy with unfractionated heparin or low molecular heparin when the INR drops below 2. So low molecular heparin should be held in the morning of the procedure, and unfractionated heparin should be stopped 6 hours prior to the procedure. So both can be restarted 6 to 12 hours after the procedure and should be continued until the INR is above 2. Already it is explained in the previous table. The other is for whom are we going to continue anticoagulation without interruption? especially those who are on aspirin antiplatelet therapies like aspirin, doesn't increase the severity of the bleeding, perioperative mortality, as well as bleeding complications are rare. So it's recommended to continue aspirin, especially in the first trimester procedural abortion. For those who have combination therapies, anticoagulant with antiplatelet or combination of antiplatelets, it needs to be consult. Hematologist should be involved whether to continue, interrupt, or discontinue. So after the procedure, the next thing will be post-abortal long-acting reversible contraceptive. Especially, we should consider post-abortal contraception for this women. Of the post-abortal long-acting reversible contraceptive, one is copper IUCD. So copper IUCD is associated with potentially heavier and longer menses, which will increase the blood loss, and it's not commonly recommended, especially in von Willebrand disease. Generally, it's not recommended for those who have bleeding disorders. As the United States medical eligibility criteria, in women with VTE or on anticoagulation for at least 3 months or on acute venous thromboembolism, copper IUD is in category 2, in the category 2. And the other is levonorgestrel IUD. So studying with bleeding disorders on anticoagulating women have shown that reduced blood loss, high amenorrhea rates, and improvement of quality of life. So it's promising contraceptive for treatment as an treatment option for these women. And it can safely be offered for these women. It's likely to improve their bleeding. It's grade 1A recommendation by the Society of Family Planning, and it's also category 2. The other is etonogastrial implants. It's not well studied in those patients with anticoagulation, and the risk of irregular light bleeding should be weighted over the potential amenorrhea. So we should balance this, and we can provide this, and it can be inserted without interruption of anticoagulation. As long as the patient is in the therapeutic range, there is no need to interrupt the anticoagulation for the sake of inserting these implants. It's also category 2. Our next topic will be on management of abortion in individuals with thrombotic disorders. Compared to the general population, women with inherited thrombophilias have increased risk of thrombosis. Especially, the most clinically significant abnormalities include antithrombin and protein C or protein S deficiencies are the most clinically significant abnormalities. Also, mutation factor 5 and prothrombin gene are also quite common thrombotic disorders. From the acquired one, antiphospholipid syndrome is one of the acquired syndrome which will increase the risk of thrombosis, and history of venous thromboembolism also is one other risk factor which will increase 3.5 times more likely to have recurrent thromboembolic events in subsequent pregnancies compared to those who doesn't have venous thromboembolic history. So when we look peri-abortion period versus venous thromboembolism, approximately half of the thromboembolic events occur in the peripartum period, and the rest half occur in the postpartum period. But there is little data about the risk of venous thromboembolism after abortion. There is little data. So the method of abortion, the choice of the method of abortion there is no data to choose the method of abortion, whether DND or labor induction. Which one is safer is still there is no data. But given the immobility of often results in associated high risk of venous thromboembolism, DND is a preferred option here. So DND is a preferred option here. And venous thromboembolism prophylaxis in peri-abortal period. So this prophylaxis, venous thromboembolism prophylaxis, can be given for those with history of venous thromboembolism to reduce the risk of recurrent venous thromboembolism. So this prophylaxis will increase recurrent venous thromboembolism by around 75%. And we would also assume risk reduction pain prophylaxis is in the period surrounding abortion would be similar. We expect same during abortion too. So these are American Society of Hematology guidelines on venous thromboembolism prophylaxis. So these are individuals who are candidates for this venous thromboembolism prophylaxis. The first one is women with a personal history of unprovoked or hormonally provoked venous thromboembolism. The other is women with antithrombin deficiency and family history of venous thromboembolism. The third one is women with homozygosity in factor V Leiden and or combined factor V Leiden or prothrombin gene mutation, regardless of their family history. So if this either of the three things are the three conditions are present, we can start venous thromboembolism prophylaxis. So the choice of anticoagulant is the other issue. Any standard coagulant would be appropriate, but low molecular heparin is recommended as a standard prophylactic dose or intermediate dose in the postpartum setting. And warfarin recommended at doses to produce around 2 to 3 INR of 2 to 3. So generally, low molecular weight heparin is a standard prophylactic dose. So prior to abortion, anticoagulation initiation, individuals, especially who have multiple risk factors and determined to have a high risk of venous thromboembolism and who are not currently on venous thromboembolism prophylaxis, has to be offered anticoagulation prior to the pregnancy if the procedure can be delayed. But we shouldn't delay the procedure for the purpose of prophylaxis only. So for those who have not an emergency indications, non-emergency indications, we can proceed without providing the prophylaxis. For those who have no non-emergency indications, we can delay and we can start the anticoagulation. So low molecular weight heparin, as I have said, is a standard prophylactic heparin, and 40 milligram daily enoxaparin, for example, can be initiated prior to the procedure, and it should be stopped, as we have discussed previously, 24 hours in advance of the procedure. So duration of anticoagulation after abortion. There is no evidence on how long the period of increased venous thromboembolism after abortion. So there is no evidence for post-abortal VTE. So there is no evidence about optimal duration of anticoagulation. So for high-risk individuals, as experts recommend that high-risk individuals can be offered around anticoagulation for around 4 to 6 weeks post-procedure. So this is expert opinion, and this is 4 to 6 weeks is the recommended time. The other is in case of emergency like incomplete abortion, we can proceed without anticoagulant prophylaxis, and since abortion has surgical management of abortion has lower predictable blood loss management option compared to expectant and medical management, surgical management should be offered for those with incomplete abortion. So surgical management is recommended. It's grade 1C recommendation. So we should emergently provide the abortion service. So finally, these are my references. I'll return you back to Dr. Rosalita.
Thank you very much, Dr. Eskinder, for the elaborate and insightful presentation. We heard from him from the patient profile as to how to navigate with patients with bleeding disorder and having to have abortion procedures or any form, whether it is medical or procedural. And then also, how do you navigate around those with thrombotic disorders? But what is clear in all the presentation is that you have to apply multidisciplinary approach in the management of the patients, and they are high-risk patients that is preferred to be managed at hospital level, not at primary care level. Referral to a hospital-based provider is required. Because they are at higher risk, their management has to be multidisciplinary. So thank you very much. We'll have other session, which will be the expert opinion. And this will be provided by Dr. Demsash Hailu. So Dr. Demsash Hailu is an assistant associate professor of obstetrics and gynecology at the University of Gondar Comprehensive Specialized Hospital. He is the subject matter expert of the development of the National Comprehensive Abortion Care and Family Planning Manual for healthcare providers in Ethiopia. He is also a 2025 Winter University of Michigan African Presidential Scholar at the University of Michigan. Welcome, Dr. Demsash. You may proceed with your presentation, sir.
Thank you. Thank you for your kind introduction. And thank you, Dr. Eskinder, for your nice and wonderful presentation. This is really a very important topic for an incoming OBGYN that will definitely will face such a case across their working time. So, as you mentioned, my important message will be always a multidisciplinary team discussion and outlining the management plan before deciding whether to interrupt the anticoagulation or to continue with anticoagulation and risk the woman with bleeding. So it depends always on the case at hand. What's the reason for anticoagulation? How much is the risk for thrombus formation when this anticoagulation is interrupted? And how much bleeding are we expecting depending on the level of anticoagulation, depending on the gestational age, depending on other circumstances that may increase or decrease the risk of bleeding. So if I say 2 or 3 important points, one thing, always prefer procedural abortion than medication abortion because the bleeding is always predictable and it is at your hand and control. And the other important thing is whenever you face such a client, sit down and discuss with other teams that have stakeholding to manage such cases and prepare ahead well. Like you said, it's not an outpatient procedure. It should be at hospital level with all things prepared around and anticipate the worst and manage the woman accordingly. And then choose the contraceptive options wisely for that woman because those women are at some point at the same time at risk of contraceptive complications. So we have to check with the medical eligibility criteria which contraceptives are good options and which one to avoid. So the management will not stop by doing the abortion. We have to also counsel to avoid another episode of another round of such dangerous and unplanned or unintended pregnancies that will put the woman's life at risk. So if there are questions, I may jump in to answer after Eskinder. Thank you.
Thank you very much, Dr. Demsash. We actually have a chat box wherein we can drop our questions or we can raise hands to ask questions and then a response will be provided. Thank you. Am I being heard, please?
Yes, we can hear you, Rosa.
Okay, so let's flood the discussion with questions or comments on them. All right. Dr. Chidima, you have the floor. While I'm going through the
Thank you
chats.
so much, Rosa. Thank you, Rosa. Thank you, Eskinder, for this brilliant presentation. I don't know if I'm allowed to stir the waters a bit. So, brilliant. I think the presentation focused on an elective abortion. So my question is going to I'm asking if a patient presents for an emergency termination of incomplete abortion. So she needs an evacuation. A patient with a known bleeding disorder already on anticoagulant, because it's a more common presentation than the electives. I know this is a Watog program, so we are from different countries. In some countries, abortion, they have the restrictive abortion law, so rarely would we see an elective abortion. But patients who probably have initiated termination and then report to the hospital with incomplete, currently bleeding, a known bleeding disorder or thrombotic disorder patient who is on anticoagulant. How should this patient be managed? Thank you.
Okay. Dr. Eskinder, did you get the question, please?
Can you please tell me again? Sorry.
I mean, I
So,
can jump
okay.
in because I heard it well.
Okay. Okay, sir.
Yeah, you are right. We will get clients or patient with an emergency situation with bleeding and incomplete abortion while on anticoagulants. So again, like the presenter, Dr. Eskinder mentioned, if it is a first trimester, the amount of bleeding is somehow not significant that to lead to the level of anemia anyway. If you are going to choose between medication versus procedure, I would always suggest to go for procedural abortion. And as we know, uterus will stop bleeding by the power of uterine contraction. So we have to be aggressive in the management of this uterine contraction. So we hope there is no other lacerations that leads a function of platelet. But anyway, if it is really first trimester incomplete, you can directly go with the evacuation, and there is not that much risk of bleeding, extensive bleeding. And if it is second trimester again, and if the INR is really deranged, and we don't have time to reverse this anticoagulation, we just go for evacuation again and try again other reversal methods, vitamin K and other things. But again, there is not that much risk of bleeding because of extensive, if there is no an extensive laceration or other damage that needs the platelets function. So be aggressive on uterotonics and manage the bleeding. So that will save the day if a woman come in emergency situation.
Thank you very much, Dr. Demsash. So there is another question in the chat box that says, what do you think is the most undiagnosed coagulopathy in African women presenting with recurrent miscarriages? The most undiagnosed coagulopathy in African women presenting with recurrent miscarriages. That's the question posed in the chat box.
Actually, I didn't get a study under this topic where I didn't get the exact prevalence of this coagulopathy, especially in the African context. But generally, from the inherited ones, von Brand disease is the commonest, and from the acquired ones, especially for those women with recurrent miscarriage, the antiphospholipid antibody syndrome is the risk, usually the most common cause of recurrent pregnancy loss. So I didn't get a paper on that, but antiphospholipid syndrome is a common scenario that we are facing here.
Okay. Thank you, Dr. Eskinder. The floor is still open for questions, comments, inputs, because this is an interesting topic. Okay, let me see. Okay, somebody said thank you. I think Dr. Abib said thank you for your excellent presentation. Any further comments, questions regarding the topic at hand? We are discussing management of abortion in bleeding disorders and thrombotic disorders. Okay, so there is another from Jackie. What is the ideal blood product to transfuse for these patients? The ideal blood products to be used or to transfuse for these patients who present with bleeding disorder or thrombotic disorders.
Okay. Thank you, Jacqueline. The blood product matters based on the problem that we encounter. For those who have anemia, we better give packed RBC. For those with platelet deficiency, especially below 50,000 or any bleeding diathesis with platelet deficiency, platelet transfusion is an ideal there. And the other is if there is coagulation factor deficiencies, as plasma, fresh frozen plasma is will be an ideal. So it depends based on the type of the problem. The bleeding disorder matters for the transfusion. So most commonly we encounter anemia and hemorrhage, so we transfuse is packed RBC.
Okay. Another question says, in your experience, how often are women presenting with miscarriages in Africa context screened for underlying coagulopathies before a subsequent pregnancy?
Generally, in our setup, women, especially for the first time, women are not screened, but women who have recurrent miscarriage, especially those who have 3 or more spontaneous abortions, 3 or more recurrent spontaneous abortion, or 2 or more abortion with especially the second trimester, are suspected to have this coagulopathy, and they are screened. Otherwise, we don't routinely screen this for this condition, especially for those with miscarriage. Otherwise, for the general population, bleeding diathesis is one indication for screening. Otherwise, for pregnant, we screen only those who have recurrent miscarriage.
Okay. All right. The others are pleasantries and thank you. Let me see if there are hands up or not. You can still raise your hand and ask if you don't want to type in a chat box so that we all go with enlightenment from this discussion. So, what I wanted to know a little about Ethiopia would be regarding the abortion laws there, because for us in West Africa, especially my country, Sierra Leone, We have restricted abortive laws. We mostly manage post-abortion complications. Abortions are only offered for women with medical conditions that are life-threatening. So what is the abortion laws like in Ethiopia?
I think better Dr. Demsash has responded this.
Yeah,
Indeed.
yeah, thank you. So again, like Sierra Leone, our country's law is also called a restrictive one, but allows for certain conditions, like you said, for those medical conditions that will threaten the life of the mother is one of the indication. Others are like when the pregnancy is because of rape or because of incest, or if the girl is minor underage, or if there is a lethal or incurable fetal deformities that is confirmed by a radiologist or an OB/GYN. So we do have somehow a relaxed kind of law compared to other African countries, but still it is restricted to some certain indications. So this law is revised in 2005. Before that, we do have also a very, very restrictive kinds of law, like Sierra Leone, like you mentioned, only when the pregnancy endangers her life because of serious medical conditions. So otherwise, we do have those indications.
Thank you very much, Dr. Demsash. Dr. Chidiva, you are saying the law is less restrictive, except if you are not caught. If you are
Yeah.
caught, you will find yourself in serious problem.
No,
Yeah.
I mean, based on the grouping, I'm aware that Sierra Leone, Ghana are less restrictive. Nigeria is restrictive. There is no condition in which is allowed, whether for mental or medical reason. That was what I was trying to draw your attention to. Thank you.
Okay, yeah, it's true. Last year, they even tried to start the Safe Motherhood Bill, but it wasn't successful. The religious people got ahead, and then we are back to starting a new strategy. Okay. Jackie also posted, how about those patients with sickle cell disease? Is there any special management plan when it comes to abortion and management, or can we treat and manage like we will manage patients in coagulopathy, with coagulopathy rather? So
Actually,
yeah.
Actually, I didn't come across on the sickle cell anemia, especially in these patients. I didn't came across with that.
Hello, am I being
Yes.
heard?
Yes, I'm hearing you.
Okay. Okay.
Actually, I didn't came across with the sickle cell anemia disease and abortion. I didn't came across with that, and also it's not common. Especially we didn't see case of sickle cell anemia here, and I didn't came across. Sorry for that.
Okay. Somebody is saying, thank you so much, Dr. Eskinder. It is a very important topic. It will be very helpful if you share your slides on the group. And
Okay.
the rest are pleasantries. Any more questions, inputs? This is a very educative topic, okay. So somebody actually responded. Dr. Chidiman posted that sickle cell patients are not on routine daily anticoagulants. So their procedure can go as planned. Right. So based on the discussions we've had so far, we had from Dr. Eskinder presenting on the patient profile, starting with a 40-year-old primigravida that was 8 weeks and had a mechanical valve, was on warfarin, and then made a presentation about that. And they went on to do other presentations. But in all of the presentation, what was highlighted as key messages that we'll take along is that when we have patients with high risks of bleeding disorder or thrombotic disorder, their cases should be managed as a multidisciplinary approach involving, if you need a cardiologist, hematologist, not just the obstetrician, gynecologist, sure, and that their care is supposed to be provided at hospital-based rather than outpatient basis, because there are risks for them bleeding or some of them having thrombotic events. And we've also learned that some of the risk factors that will increase their risk of bleeding will be higher gestational age, like those in the second trimester, multi-fetal gestation, those who have had previous uterine surgeries, abnormal placentation, low HP. So those are considerations we should take in when we are trying to plan our patients who will need medical or procedural, but from the expert opinion, procedural termination of pregnancy or abortion is the preferred because of the predictable blood loss as compared to the medical methods, which is unpredictable. So I saw the hand of Dr. Alimo. Please go ahead.
Thank you very much for this nice presentation. Am I audible?
Yes, please.
Yes, yes.
Thank you. This is Alemu Aja. I'm from Ethiopia, who is doing my residency OB/GYN program in Kenya, where we have a big cardiothoracic open heart surgery. Because of that, we are facing a lot of pregnant mothers and ladies who are presenting with pregnancy-related complications. So I want to know, because we have some debate about the patient who are presenting with mitral valve, any valve replacement in the patient usually on warfarin, and then they are presenting with some bleeding problems, especially in abortion. And when INR is therapeutic, multidisciplinary team, we are usually pushing to different perspective of management. So as a family planning expert, what you recommend for those patients who have therapeutic target INR and the patient who is in warfarin and present with bleeding who needs urgent management? What is your recommendation on that?
Thank you. Dr. Demsash, are you with us?
Yes. So, I mean, if I got the question, are you saying any cardiothoracic surgery while the woman is pregnant, or what?
Sorry, let me clarify more. So the patients in our hospital, usually the patients are coming to the follow-up, and sometimes they might miss the counseling on family planning, and they become pregnant while they are on warfarin. Some of them come with amazingly with missed AB. Some of them are coming with spontaneous AB, and at that point we are just in debate of go ahead and do if it is emergency, go ahead and do with evacuation if INR is okay, and then the other team is saying it is let's reverse it, even though if it is therapeutic, and stop the warfarin and give time and just continue with just let's put her on low molecular weight and then give her time. Those debates are there. So especially for the patients who have normal target INR, but the others it is just, I think it is agreeable. So what would you say the patient who have normal target, which means 2 to 3 INR, who are on warfarin, presented with abortion, which needs evacuation as emergency? How can we approach those patients?
Yeah, thank you. Now I got your question. So, as Dr. Eskinder presented, so it depends on the discussion between the 2 or 3 responsible departments, a cardiologist, the hematologist, or obstetrician. So, anyway, if the risk of thrombosis, whether it is mechanical heart valve or other high-risk medical conditions, if thrombosis risk outweigh the risk of bleeding, and on top of that, our baseline knowledge is if it is first trimester and should undergo an abortion, the bleeding is not that much to the level to lead to anemia. So you can go ahead with the procedure, even like you said, with normal INR. So it depends on the risk of thrombosis versus the risk of bleeding. If it is second trimester and with other additional risks, I think this is a time to hold warfarin or transition to other heparins, take time and go for evacuation process. So it depends on the risk of thrombosis. It's a comparison. It is choosing one of the 2 devils. So if the risk of thrombosis is really high, and if it is first trimester, you can go ahead with the procedure without interrupting this warfarin. But if it is really a bigger gestational age with high risk of bleeding and on an anticoagulant, that is a period to discuss, maybe to change it to heparins and do the procedure and reinitiate again this warfarin. So it's always a choice between comparing or outweighing the risk of thrombosis versus risk of bleeding. So it depends on, we always should manage on case by case basis.
Thank you very much, Dr. Demsash, for that insight. I think the last post here is the president thanking the organizers, presenters. Okay, so the other part of the summary is that the contraceptive use post-abortion is individualized. Options available that we have mentioned were the copper T, IUCD, the levonorgestrel, triacin system, and etinogestrel. But then their use has to be individualized based on the patient's situation. So even the use of anticoagulant, when to stop, when to reinitiate, all has to be individualized based on the type of anticoagulant used. So the slides will be shared for us to go through. If there are no questions, comments, I would like to thank the panelists, Dr. Demsash Hailu for taking his time to provide expert opinion for us. We dearly appreciate your time and your knowledge shared with us. And then Dr. Eskinder and the department for such a wonderful presentation put together to share with us your information and even your discussion. We really appreciate. And then for the participants who were very participative in terms of asking questions as well as keeping the house quiet. And then I also want to thank our organizers for such a wonderful and insightful case series. We are hoping to get the order in the next 2 weeks on the Saturday. Without much I will say thank you all from Sierra Leone, and then can we please put on our camera so that we'll have the screenshots that we do, and then we can then go in peace. Thank you all.
Thank you so much.
For the last
thank
photo.
you. Bye-bye.
Yes.
Okay.
Okay. It's like some people are not here. Let's try to have a photo. Oh, it's like 4 people are available for the photo. Anyway. Great. Okay, let's give some time. This network problem. Okay. This is lovely. Okay. Thank you, thank you, thank you from Sierra Leone. Take care. Thank you, Dr. Eskinder.
Thank you, Dr. Eskinder. Beautiful presentation.
Thank you.
Hey, thank you, South Africa, for the host. Thank you for hosting us on Teams. Thank you, Rosa.
It's a pleasure, everybody.
Thank you, everybody, for your attention. Thank you.
Thank you, everyone. Lovely evening.